Thank you. So, good evening, all our members of Maharashtra Ophthalmological Society, all our members who are also joining at large from the other states as well, and especially welcome to our young stars, our postgraduates who are joining us today from every corner of Maharashtra and beyond. We all know that Maharashtra Ophthalmological Society, one of the aims for us is always to uplift and educate our postgraduate students, and this year, we have been doing it every month by dedicating one subspecialty to each month. We have so far covered many other subspecialties, but this month is special because we are going to cover something that is very niche, very important, that is pediatric ophthalmology. Today, we are very lucky to have Dr. Krishna Prasad sir from Joshi Eye Hospital as our national faculty and panelist. Along with him, our own Dr. Nikhil Rishikeshi from Pune and MOS faculty from the Agarwal's Eye Hospital. Today's session is going to be mentored by Dr. Satish Shitole and Dr. Hanumant Mandlikji. And of course, this will be moderated by Dr. Kriti Shah. And two of our young stars are going to present very important and common cases. And we are going to have a lot of threadbare discussions and also many, many practical points that will be taken away. So we would like to thank from Team MOS, the coordinator for this year-long PG program, Dr. Sumit Lahane, who has tirelessly worked throughout the year and especially for this month for the pediatric ophthalmology session. So now I would like to invite our president, Honorable Dr. Santosh Agarwal, sir, to please deliver his presidential address. Over to you, sir.
Thank you, Dr. Vardhaman. Good evening to one and all. I welcome you all to this unique webinar for PGs, especially for PGs on pediatric ophthalmology. At the outset, I thank all the faculties, especially Dr. Krishna Prasad sir, Nikhil, Dr. Nikhil, Dr. Shitole, Dr. Hanumant Mandlik, and our own moderator, Dr. Kriti Shah, and the grace presenter Aishwarya and Priyanka. So I welcome you all and I thank you from my bottom of my heart for taking out time for this webinar. And today we are going to discuss the pediatric ophthalmology cases. I feel pediatric ophthalmology is a very difficult subspecialty in terms of examination techniques, which are very different for pediatric patients, because it is not easy to examine the pediatric patients. There are different techniques, and the experts will definitely highlight the importance of different techniques, and they will also give their pulse of wisdom in different types of cases which we encounter in day-to-day practice. It will definitely helpful you in examination also, and how to face the viva, what are the questions which are asked, how to answer the questions. So definitely it will enlighten all of us. And I appeal all the PGs and fellows to come out with your cases, present it, and also ask the questions. Whatever queries you have, please forward it to Dr. Sumit Lahane or anybody of us so we can answer your queries. And our experts are there who have taken out time from their busy schedule. So I am very much thankful and grateful to them. So thank you very much. And over to Vardhaman, please.
Sir, your quote is removed.
My quote is, today's quote is, the hallmark of successful people is that they are always stretching themselves to learn new things. Life is not a problem to be solved, but a reality to be experienced. Be fighter always. जहां कोशिशों का कद बड़ा होता है, वहां नसीबों को भी झुकना पड़ता है. Thank you very much.
Thank you, sir. So well said. I think your quotes in every PG program definitely inspires all our, not only residents, but all of us. So thank you for your presidential address and all the support, sir. Now, without further ado, I would like to now give the reins of today's webinar to Dr. Sumit Lahane, our Chief Coordinator, and to Dr. Kriti Shah, our moderator for today. Over to you, Sumit.
Thank you, sir. Thank you, Team MOS, Santosh sir, Atul sir, Vardhaman sir, and Aditi ma'am for providing this platform for PGs all over Maharashtra. And we would like to introduce our panelists and the mentors for today. The panelist is Dr. Krishna Prasad sir. He does not need any introduction. Sir is the head of pediatric ophthalm and the glaucoma services at prestigious MM Joshi Eye Hospital in Hubli. Sir had 8 gold medals during his MBBS curriculum, and sir did his pediatric opthal fellowship, and he is a AIMS alumni, and he is an inspiration not only to the student but for the teachers like me as well. And he is someone who can teach any part of ophthalmology during any time of the day or night, and during the any time given. Thank you, sir, for being here and accepting the invitation just on a single message. We have Dr. Nikhil Rishikeshi sir. Sir is our own MOS faculty. Sir is based in Pune and he has over more than 24 years of experience. Sir did his pediatric opthal fellowship from Delhi AIMS under the guidance of Pradeep Sharma sir and in Pune. Sir has mentored many of the fellows and the postgraduates, and he inspires everyone to become a pediatric opthal. Sir, thank you for being here.
Thank you.
Our panelist for mentors for today is Dr. Hanuman Mandlik. He is the associate professor, again pediatric ophthalmologist, working at Bharati Vidyapit Sangli. And we have Dr. Satish Chitore sir, who is again associate professor from BJ Medical College, Pune. Thank you for being here. Our actual real heroes for today, Dr. Priyanka Maurya, who is from Vedanta Medical College, Mumbai, and Dr. Aishwarya Pandarikar, who is again from Sangli, will be presenting their cases today. And to handle the show, we have our able moderator, Dr. Kruti Shah, who is a dear colleague and is again a very able pediatric ophthalmologist working in Mumbai. She did her pediatric ophthalm fellowship from Arvind Madurai and working in Mumbai presently. Thank you, Kruti, for accepting to moderate this show. And I hand it over to you, and we'll start with the Dr. Aishwarya's presentation. You need to unmute, Kruti.
Good evening, everyone. Thank you so much for the invite, and I'm very thrilled to be here. So we have two cases today. One is infantile esotropia and one is DRS. Nikhil sir and KP sir, can we start with infantile ET?
Yes, please.
Okay, fine. And just before I go ahead, just one thing, KP sir, as when I was a student, I was a great, huge fan of your work. I've attended all your PG programs at Hubli, and it was too much fun learning from you. Yeah.
Now it's the reverse. Now I'm very keen to actually see what I can learn from you.
Sir, student is always a student.
All the best. So you're never-ending fan club, huh, KP sir?
Yeah. Yeah. So infantile ET, we'll start with that. Please share your slide.
Can I start now?
Yes, yes. Please do go ahead.
Everyone, I'm Dr. Aishwarya. I will be presenting a case
Sorry,
today.
just one sec. Do you want to make it full slide? Yeah. Okay.
Yes. I'll be presenting a case today. A 6-year-old male child was brought to ophthalmology OPD by his parents with the chief complaints of deviation of right eye since 6 months of age. Child was 6 months of age when his parents first noticed inward deviation of right eye, which was insidious in onset and gradually progressive. They gave no history of any abnormal head posture, no history of diplopia, no history of fever, neck stiffness, or seizures, no history of head injury or fall, no history of wearing any previous spectacles, and no history of patching of the eye. Past history was not significant. Family history not significant. No history of consanguineous marriage of parents. Coming towards the birth history, patient was a child was a full term normal vaginal birth delivery. No history of any NICU admission. Birth weight was 2.5 kgs. Immunization was done up to the date till 6 years of age, and milestones both gross and fine motor were achieved at appropriate ages. Coming towards the ocular examination, Starting from the visual acuity, on Snellen's, child gave 624 vision, not improving with pinhole in right eye, and 69 improving with pinhole to 66 in left eye. Coming towards the sensitive examination, on Worth 4 dot test, patient showed right eye suppression. Coming towards the extraocular movements, Ductions and versions were full and free in all cases. Both abduction and adduction were within normal limit. No abduction deficit. Coming towards the versions, in primary case, patient had right eye esotropia. Both liver elevation and dextral elevation were within normal limit. No evidence of any inferior oblique overaction. No apparent evidence of A and B pattern seen. Coming towards the motor examination, according to the Hirschberg corneal reflex test, we saw 30-degree esotropia in the right eye. On cover and cover test, there was right eye esotropia. On alternate cover test, both eye alternate esotropia with left eye dominance. On prism bar cover test, it was 60-degree PD in the right eye. We did wet retinoscopy with cyclopentolate. With right eye was plus 0.25 spear, same with the left eye. Coming towards the anterior segment evaluation, which was not significant, not abnormal. Eyelids were normal in both eyes. Conjunctiva normal. Cornea size, shape, surface normal in both the eyes. Sensations intact. Transparency clear in both eyes. AC depth was VH3 both eyes. Iris color was brown in both eyes. Pattern regular.
We can tell only the significant findings, no? Is really. Otherwise, you can say it is within normal limits.
Yes, anterior segment as well as posterior segment was within normal limit. Coming towards my provisional diagnosis, patient has infantile esotropia with left eye dominance.
Yeah. So, a very good presentation. KP, sir, we would start with you. What would you ask the candidate?
Okay. What is the age of the child now, you said?
It is 6 years old, sir.
6 years. What is the history? Like from almost birth or 6 months of age, they have been.
Yes, sir. From 6 months of age, patient started, the parents started noticing the deviation of vision. They didn't show it to any ophthalmologist. They presented to us in our OPD at 6 years of age.
Did you bother to check any old photographs and what is the significance in the world? Nowadays, it's very easy with the mobile phones. Okay. What is the actually significance of old photographs? In this case or in any case of squint?
So to see the progression of the strabismus.
Okay. I'll ask you something. See, like this patient, okay, let us assume that I'm not diagnosing it, the infantilism. Normally, and here, do you think that the child must be having esotropia in right eye only since birth till now, or it has been alternating? Sometimes the child is seeing with left eye, sometimes with the right eye, or at all times that you see the child. For example, you steal a glance around 10 times at a child. Okay. At how many times you think that the left eye is fixing, at how many times you think the right eye is fixing? If you think that at all times the left eye is fixing and the right eye is deviating?
No, sir. There was alternate fixations.
No. Alternate fixing, the child is spontaneously alternating. Like when you're seeing without any provocation, the child suddenly shifts fixation to the right eye, deviating the left eye. So
when I was examining the patient, the child was majorly fixing the right eye, sir. Sorry, left eye, sir.
No. Spontaneous alteration, alternating squint is little unlikely because the child is having 624 vision in the right.
Yes.
Why will a child fix with the 624 eye unnecessary? It will always fix with the 66 eye. 624. Yes. So, how do you explain that 624 vision that the child is having constant esotropia in the right eye since birth? Do you think it can be explained?
So you're trying to say, no, Aishwarya, that the child may have amblyopia, right? Because she's preferring fixation with the left eye, correct?
I was just coming to that. So, in the diagnosis, did you mention amblyopia?
No, sir, I haven't.
Amblyopia is a major cause of blindness. Definitely, or unfortunately, it's a preventable cause.
Yes.
The idea of MO is doing this webinar, sensitize you all youngsters about a major problem. So we are being the cause of blindness. Even though the child may have 6 vision in each eye, a child has a constant screen, the child is practically one eye. So your sensory examination will show suppression of one eye, right or left. So even though the vision is 6 in each eye, because we are not corrected the screen, the child is actually seeing with one eye all the time. It's a major cause of visual morbidity. So you have to be sensitized about. Obviously, it has to be in your diet. Because
Yes.
the major problem hurdle in the treatment of this case because she is 6 years old.
So very good point. Thank you so much for the insight. And actually, I have Dr. Satish to ask first few questions, and then I'll come get back to you, sir.
And I'll expect Dr. Nikhil to continue because we had an idea that probably one will dominate and other will like a sprint, no? He said there's a
Okay.
dominance.
I thought sir would go ahead with
Nikhil will
DRS.
dominate ET and I will dominate DRS.
Okay, done, sir. Fine. Absolutely fine. Okay, Dr. Satish. Sir, am I audible, sir?
Yes, you are audible to me.
Yes, sir. So would you like to ask questions to Dr. Aishwarya? And how would you comment on our presentation as well?
Question is good. I want to ask what kind of psychological drug she has used for the assessment and why?
Sir, I have used a cyclompentolate for my wet retinoscopy.
Okay. Why you have used cyclopentalase?
Sir, a patient is a 6-year-old kid. And cyclopentalate has the period of action is from 6 to 18 hours, sir.
Any adverse effect you have noticed in patients when you use cyclopentalate?
Sir, this burning sensation, redness.
Cyclopen psychosis, have you heard any time?
Why do we use cyclopentalate only in clinics? We don't give it for home dilatation.
Sir, it might induce seizures, like one of the side effects of seizures.
Is it the role of in the management part? Is there a role of refractive correction?
Yes, sir. In this patient, first mostly majorly we do surgery, sir. But in patients which have more than 3 diopters of hypermetropia, in that cases we give glasses to the child.
Okay. Can you talk something about the management of specifically about this case?
Yes, sir. So about this management, we have 2 types of management. One is non-surgical and one is surgical. Like I said, for non-surgical, in kids which have +3 hypermetropia, we first try to give glasses to the patient and try to correct amblyopia before going towards surgery. Coming towards the surgical management, we have few prerequisites which we must ensure. First up is like the patient has deviation is constant and stable. Accommodation is not present. And after that, most common preferable surgeries are bilateral medial recession.
Thank you.
Nikhil, sir, as we decided, you will be talking on infantile ET. So would you like to add on for the management part?
Yeah, I mean, before we reach the management, first we have to establish a diagnosis. First, we have to talk about the amblyopia, whether it is strabismic amblyopia or is there something behind it. And if it is amblyopic, and so this is basically kind of a monofixation because the left eye is taking a fixation, the right eye is suppressed. So we need to know what is it, whether a TNO test was done or not. Obviously, if it was done, you will probably get that the right eye is suppressed. So for the sake of completion and for the sake of exams, you need to mention it at least. What was the whether there was any binocular single vision, whether there was any fusion, gross fusion at least. Because for near, the child may have, may not have. Obviously, he will not have fine stereopsis because of the amblyopia. You had mentioned in history that there is no history of diplopia. So from what I remember, whatever you are putting in there, there should be a logic behind it, or there should be some, because if you are questioned, cross-questioned, and you are asked, did you expect diplopia in this case? What would be your answer?
No, sir, I did not expect diplopia. Diplopia usually occurs in the lateral rectus palsy patients, sir.
So that if there is some incompetence, if there is some paralysis, so if there's a concomitant deviation, and the child is already having 624, and the right eye is suppressed, that means the brain is not really acknowledging the signal that comes in from the right eye. There is zero possibility of a diplopia. Then just for you to understand it, you've already mentioned it, but it's important that you talk about it. Similarly, about the AHP, or the abnormal or compensatory head posture, as it is better known, would you be expecting something like this, that in this case?
So, paste we can expect in this patient, sir, due to the abduction deficit.
You said moments are full, no?
You mentioned
Moments
an
are full,
abduction
sir.
deficit?
Not exactly in this case, in any other infantile esotropia case, I'm talking about.
Very rare, very rare. The only one instance in which there can be a little bit of compensatory head posture is if there is one eye dominating the other eye, even if the vision is equal, which is very rare, because the stalwart sign of infantile esotropia is cross fixation, isn't it?
Yes.
Cross fixation.
Yes, sir.
So that's the next point. I'm sure KP sir will agree to it. Very rare to get amblyopia in a case of infantile esotropia, because both the eyes will normally have equal vision. Even if there is a little bit up and down, it will be half a line. So 624 and 66, I have almost never seen in an infantile esotropia because of it being a cross fixation. Since both eyes are fixing in a cross manner, none of them is amblyopic. But would you expect in, let us suppose that if it was 6966 or 6666, what amount of stereopsis or BSV would you expect in a child having equal vision, good vision, with infantile esotropia? Binocular vision or stereopsis? Because that is what we, all of us as strabismologists, that is what we strive for in children. Stereopsis and binocular single vision.
Yes.
So would you expect good stereopsis? Wouldn't you expect if the vision is 6666 in infantile esotropia?
So the normal stereopsis will expect some.
In infantile esotropia. Because the vision is normally good, 6666.
Yes.
But since the insult is very early in life, almost never will they have good stereopsis. This point is for everyone to understand and remember. And that is the only downside of this infantile esotropia, that the stereopsis or BSV is very poor or underdeveloped, and you do not expect it to develop even after early surgery, although it be slightly better with early surgery than with late surgery. Is that okay? Is that
Yes,
very
yes.
clear? And that is the
Yes.
biggest downside of infantile esotropia management. Is that
Sorry
okay?
to interrupt you, Aishwarya. You stop sharing, and Priyanka, you get ready with your slides. Okay.
So I think one point here, which is important, and KP sir would agree, is the diagnosis. I would not say this is an infantile esotropia. I would say this is an esotropia which has occurred in infancy probably, because the signs, the main signs of infantile esotropia, like I already mentioned, is almost equal vision, cross fixation, alternation.
DVD.
Yeah,
No, that
DVD,
is
inferior
syndrome.
oblique overaction, that is later. All of that will be associated. But 624 and 66, not infantile esotropia, almost never. Okay.
Okay, sir.
It is mostly a right eye esotropia, which is also very rare. It is very, very rare. Generally, it be infantile esotropia. So you need to be very careful when you, so if you are presenting as an infantile esotropia, when you read, so generally they appear at 2 to 4 months of age, they are cross fixations, there is no amblyopia or very little if at all. There is no monofixation because there is cross fixation, but poor stereopsis because the insult occurs in first trimester or somewhere abouts. Stereopsis does not develop. Is that okay? Now, in this case, you said bimedial recessions, whereas the vision is unequal. So if it is 624 and 66, there is no point doing bimedials. Is that okay? Bimedial recessions are done in infantile esotropia, you're right. But it is not infantile esotropia.
Okay.
Do you agree?
Okay, sir. Yes.
No. Do you agree?
Yes, sir.
Okay. So infantile esotropia management is bimedial recession because it is the medial recti at fault, overacting medial recti. So almost never do we do a resection of the lateral rectus. But in this case, one, we want to improve the amblyopia, bring it to 6966. We want to make it alternate fixation before we even start thinking about surgery. The right eye should start taking up fixation equally. There is no point hurrying into surgery. He's a 6-year-old boy, already critical period, 6 years are gone. We want to improve the vision. Stereopsis has no chance here. At 624, I will never touch this eye. I want to bring it to 69 at least. So patching of the left eye. If there is no refractive error, just a patching may help. If it doesn't, you have to give it a shot, at least for 2 to 3 months. And full-time patching. So according to amblyopia treatment studies, for 624, 4 to 6 hours may be enough, 2 to 4 hours may be enough. I totally disagree because the rest of the waking hours, the brain is again going to move to the left eye and ignore the right eye. So in such cases, you have to be very aggressive because you don't have time. It's 6-year-old. Once you improve the vision, then only you operate, and then we would do bimedial recessions. Even if then the left eye is dominant, right eye is suppressed, you do only the right eye surgery. KP sir.
Yes.
Yeah, I think I can't agree less. See, very important is, as I said, it's an important cause of vision. Okay, so be mindful about it. Just like all refractive and cataract surgeons are worried about 20/20 as a very important number in their life. These strabismologists said 20/20/20. Other 20 is 20 seconds of an arc is our dream.
Yeah.
Wherever possible, you should try to achieve 20 seconds of an arc. That is where he said periopsis. Periopsis is an ultimate binocular function. Simple test, we can actually know so much about the. Be mindful about stereo. As I said, correct amblyopia. Then alignment. You will never do alignment with unequal vision wherever possible. So always your aim is to equalize the vision. An alternating strabismus, a freely alternating strabismus is the invitation to this. If you can achieve that, nothing like. Okay, so this is very important. At the same time, as I said, that's why I said you need to really look into the whole photograph. And you would have probably seen the cross fixation. Sometimes the right eye fixing, sometimes the left eye fixing. Okay, you would have probably seen the alteration. Then this kind of 624, 6 disparity would be difficult to explain. Maybe there is an element of anisometropic amblyopia, we don't know. Maybe there was, probably it was there at the growth of eye. Maybe that anisometropia has come down. So there can be something else responsible for 6. But nevertheless, it deserves an amblyopia.
Yeah.
Yes. Thank you,
Okay.
sir.
We'll shift to the next case. Nikhil sir, just last question. What is the earliest stage to operate an infantile EP?
Oh, lovely. So if the vision is good and equal alternation and all of that, 6 months to 7 months, I think is the earliest that if you have established the number of prisms and if you're happy about the dependency of prism test and you have established that is 40 prisms, 45 prisms, then I would operate at 6 to 7 months, 8 months. Because the earliest we operate, whatever little chance for gross fusion or gross stereopsis is there is if you operate early. And because of that, you can avoid the DVD, which may come later nystagmus, which may come later. So for these reasons, I would operate earlier. Yeah, 6 to 9 months is what I would prefer.
Thank you, sir. Sir, in case if we don't get the deviation properly, the angle, then would you prefer Botox?
Now that Botox is, sometimes I take off the BO from the Botox, because of the unreliability quotient of it. You don't know how much it is going to correct for whom. And number one is it will never correct 40 prisms. It is the keys in the word, the talks. I'm not happy about talks for kids. And so it'll never give dependency or reliability. And that is not what I'm happy about. Plus, some people talk about medial rectus recessions with Botox. So when I was in UK at Birmingham, I have seen that being done, bimedial recessions with bimedial Botox, and the 45 prisms ISO became from 50 to 60 prisms exo.
Okay. Right.
So I'm not for Botox. And there are other indications for Botox. As we all know, restrictive strabismus, and all of those things. For concomitants, I would really keep away, especially in infancy.
Correct, sir. Okay, we shift to the next case because I think we're in short of time as well.
Yeah.
Dr. Priyanka, please upload your slides.
Ma'am, can you see my slides?
Yes, please go ahead.
Yeah,
Hare
please go.
Krishna.
Sorry.
Hare Krishna. This is Dr. Priyanka Maurya, DNB Ophthalmology resident from Bhaktivedanta Hospital and Research Institute. I want to thank MOS for the opportunity and to all my teachers for guiding me through the process. Thank you. So today I'm presenting a case of Duane's retraction syndrome. A 36-year-old female patient, engineer by occupation, came to ophthalmology OPD with chief complaints of inward deviation of left eye since childhood. History of presenting illness. Patient was apparently all right since childhood. Then her parents noticed inward deviation of left eye, which is non-progressive and constant, and it was associated with absence of outward movement in the same eye. They also noticed infrequent face turn towards the same side. It was not associated with double vision. There were no relieving or aggravating factors noted. Patient also gave history of spectacle use since last 30 years with no recent change of prescription. There were no history of patching of eyes, no history of eye strain, watering or headache, no history of ocular trauma, no history of convulsions or focal neurological deficit, no history of any ocular surgery. Past history, no history of TB, hypertension, diabetes, or bronchial asthma. Family history, her elder brother also had similar complaints, and nothing else was significant in family. Then personal history, patient
You can
denies
go
all.
to ocular examination directly, or
Okay.
yeah.
On ocular examination, head posture 15-degree face turn to left was noted. Facial symmetry was maintained. There were no other deformities observed. On examination, best corrected visual acuity in the right eye was noted to be 6/6 with 0.5 degree cylinder at 130 degree, and the near vision was N6. Other details of the anterior segment finding and the posterior segment finding were totally within normal limits. The left eye best corrected visual acuity was 0.5 degree cylinder at the 10-degree angle. Then near vision was N6. Other anterior segment and posterior segment findings were within normal limits. Then on sensory examination on neutralizing head posture, Worth 4-dot test showed normal fusion for distance. Stereopsis with TNO chart was 120 arc seconds. On motor examination, Herzberg's test showed 15-degree esotropia in left eye. Cover test showed left eye esotropia. Alternate cover showed left eye esotropia with right eye fixation preference. Prism bar cover test showed 30-degree prism diopter secondary deviation and 25-degree prism diopter primary deviation. This was the photo of the patient in all ocular gazes. Then on extraocular movements, on versions, we noted that in the primary gaze, there was 15-degree left eye esotropia. On dextroversion, left eye shows minimal limitation of adduction and decrease in palpebral fissure with grobe retraction and upshoot on adduction. On dextro elevation, upshoot seen in left eye. On levoversion, left eye shows restricted abduction, limited levo elevation and levo depression seen in left eye. On ductions, patient showed in right eye all the ductions were normal. In left eye, abduction was limited, found to be -2. Rest ductions were normal. So my diagnosis would be in the right eye, simple astigmatism in a phakic eye, and on left eye diagnosis, type 1 Duane's retraction syndrome with esotropia with simple astigmatism in a phakic eye. The differentials can be infantile esotropia or left lateral rectus palsy. Thank you.
Yeah. Very good presentation, Priyanka. You can stop sharing the slide unless and until someone wants to see the photo. And yes, I will ask Dr. Hanuman to ask the questions and then we'll go to the panelists. Dr. Hanuman, are you there?
In case he is not there, Kruti, you can ask questions to her.
Okay, fine. So, yeah. So what is DRS and what is the classification of DRS?
Duane's retraction syndrome is basically a type of congenital incomitant restrictive squint. So,
Okay.
And it is also the most common classification is Huber's classification,
Very good.
where it is divided into 3 types: type 1, type 2, and type 3. In type 1, there is a limitation in the abduction gaze, and there can be also limited adduction. So the
In type 1, there's limited adduction.
can be minimal.
Minimal, okay.
Yes, ma'am. And then the patient will present with esotropia. In type 2, there is limited adduction. So the patient will come with exotropia. In type 3, there is limitation of both abduction as well as adduction. So the patient will come with orthotropia.
Okay. And all those things, up shoots, down shoots, everything?
In all the three types, there will be presence of minimal narrowing of the palpebral fissure, globe retraction, and upshoot and downshoot. In all of these will be present in the adduction gaze.
So, okay, whatever classification you said, that was Huber's 1. Now, in Huber's 2 classification, they say type 1 abduction.
Further, yes, further
can be
division
ESO,
in
exo, ortho.
ESO,
And
exo,
type
ortho.
2 is adduction deficit with ESO, ortho, and exo. And type 3 is ortho. Okay, DRS. Okay, Dr. Hanumant has joined. Sir, would you like to ask questions? I have asked Priyanka what is DRS and what is the classification of DRS?
Firstly, it is a good presentation by Priyanka. I would like to ask what is primary and what is secondary deviation and how to measure it in case of DRS.
So the primary deviation is the deviation present in the squinting eye or the paretic eye when the normal eye is fixating. And the secondary deviation is the deviation that is induced by the paretic eye onto the normal eye when the paretic eye is fixating. And we can measure the secondary and primary deviation by doing prism bar cover test.
Yes, sir. So, you there?
I think he has internet issues. You go ahead with it.
Okay. And what are the other syndromes that you see with DRS?
So most commonly with DRS, we can see Holt-Oram syndrome,
Okay.
where there is also radial, limb defects and heart defects. And then we can also see golden hair syndrome,
Very good.
where
The most
there is
common.
jaw, cheek, and ear abnormalities on only the one side of the face. Then we can also see in morning glory syndrome, where there is optic disc anomalies. Then also in Mobius syndrome, where there is a seventh nerve palsy, congenital seventh nerve palsy. Then we can also see in Wilder-Wank syndrome.
So quite a few.
Yes.
And what is last one from my side, and then the panels would ask, what is force duction test?
So the force duction test
and how is it and how is it applicable in DRS? Okay, both.
So, ma'am, force duction test is basically used in incomitant squint to differentiate between its types, between paretic and the restrictive squint.
Okay.
So when we use the force duction test, so the examiner is basically trying to check the movement of the eye in this direction for further than the patient can move it in a direction. So
Okay, fine. So, KP sir, I think I'll give it to you. You can explain it better. Yeah.
Nice presentation, very interesting case, lot of things to discuss. Now tell me, you had some theories. You had type 1 DRS with esotropia in primary case. That's what I gathered. Had some theories, no? It said it could be infantile easy, or it can't be lateral rectus palsy, right?
yes,
I
sir.
think it's a congenital lateral rectus palsy. You have any objection?
Yes, sir.
Right.
Because the patient is also having narrowing of the palpebral fissure, there is upshoot, downshoot, and also the patient is having abduction, not complete, but the abduction limitation is also there, and the esotropia is only 15 degree. In case of left lateral rectus palsy, the deviation will be more. The esotropia will be complete esotropia.
Excellent, excellent. I think you have a knack of making it really complicated in your narration. So kind of I'll simple it for the other students. So basically, it's a concomitant. There are basically two types: competent sprints and incompetent. Incompetent sprints are divided to restrictive and parallel. It's a restrictive incompetence, whereas a 6-nerve palsy is a paralytic. So if you have a paralytic strabismus, normally the deviation in the primary A match the amount of restriction. If you have a large deviation, you will have a very severe restriction. Whereas here you have a severe restriction. The abduction is restricted, the deviation is quite less compared. Right? As Dr. Priti said, it can be even paradoxical. You have an abduction restriction with exotropy. You may have even a paradoxical, so that is possible in such. Okay. And also, very importantly, you should understand that all these retractions, palpable aperture changes are mandatory to diagnose here. There are some cases where they may be very minimal. Okay, they may not, it's called DRS sign retraction. Retraction may not be there. So in very rare cases, it's very difficult to differentiate DRS and sometimes unknowingly comprehensive ophthalmologists can confuse this palsy, make the patient. Please understand DRS type 1 is easy for lateral rectus. As lateral rectus palsy can be a serious event, DRS is innocuous. Right? Very good. So now, so with this now, patient has good vision. It has to assume head posture to sleep. Right? So what is now the diagnosis here? How would you like to manage? Number one, is there a need to manage at 36 years? You have not done anything so long. Why you want to actually treat? And what are the indications to do?
Sir, in this case, we'll not treat the patient because
Sorry, I'll interrupt. Sir, she's 20-year-old patient, and I think she wants to
35-year-old.
20, 35. Sorry. So sorry. Okay, go ahead.
She had it from birth, but she is now 35.
Now
Yes.
she's okay.
And why 30? You don't want to treat her, right? Why?
Yes, sir. Because so because the patient is having complete vision, and all the surgeries that we do for DRS don't actually solve the main problem, that is the abduction limitation. We are doing all the surgeries for the orthotropia and to maintain the head posture, to give the patient binocular single vision. So in this case, patient already
has binocular single vision even now with a head posture. You don't have to give it to her.
Yes.
But if she's damned for life with a head posture, will always be, having a face turn to left throughout her lifetime. You don't want to do anything about it if you can.
So we'll
Correct.
do correct. We'll correct.
Will you correct the head posture?
First year, I appreciate your appetite. Please go ahead. You like to correct or not?
Yes, we'll correct, sir.
Good.
Okay.
If the
Now
patient
tell
is
me, what are the indications as you have read in the text? What are the indications? Give the top 3 indications to operate or manage a patient.
to correct the abnormal head posture and to give the patient binocular single vision, and to correct all the upshoots, downshoot, globe retraction. If there are extreme or very high, then we'll correct that.
Does she qualify now? She
So,
qualify with this for treatment. She has head posture. She has an up. She has palpopulopathy. It's a cosmetic blemish.
yes.
Okay, it is also a disability that she has to head always turn to left. So obviously you can help her with the surgery. Now, can you tell me? I know you're too young to answer this, but still, since you've taken it up, what do you do in this patient to correct these problems? Surgery you will do.
So we on force duction test, first we'll check the restriction of the muscles. So if the deviation is not that much, we'll do since the cases of exotropia, we'll do the ipsilateral medial rectus recession.
Super.
And if the deviation is very large, then we'll do bilateral recession of both the horizontal recti muscles.
I would
For
suggest to do resection of lateral rectus. No, that is better. R&R.
no, that's not for
Why not?
resection.
Of the lateral rectus.
Sir, resection.
Yeah.
No, sir, resection
You
will.
strengthen the lateral. Anyway, abduction is not there. So you strengthen the lateral rectus, no, by resecting it.
So, but the resection of the lateral rectus muscle only increases the globe retraction and or narrowing of the. So, in all the DRS case, whichever the DRS is type 1, type 2, or type 3, we don't do resection of any muscles.
A good message for the beginners. Yes, we take it. Okay. So here you have 30 prism diopters of mesothelioma. So medial rectus, how much you are going to risk? Patient?
Minimum will 5 mm to 7 mm we resect.
Resect
Sorry,
means
Nikhil will take
recess.
over.
sorry, recess. Sorry.
Dr.
Yeah.
Nikhil.
Yeah. No,
Yes.
so for the eye with DRS, it's always better not to over recess the medial rectus because that can give rise to adduction deficit in addition to the abduction deficit. So you have to be very conservative in the DRS eye. Remember this, especially with ESO. So up to 20 to 25 prisms of esotropia in DRS1, and we are talking generally in lesser ages, you can do single medial rectus recession of the DRS eye, not beyond 4.5 to 5 mm, not beyond.
So
If
one
the
last.
ESO,
Sorry,
yeah.
continue. Continue.
If the ESO is more than 25, and it often is, then you will need to do recession of both medial recti. But obviously, the secondary deviation will be more than the primary. Generally, we have seen if it is 20 to 25 in the DRS eye, it will be at least 40 prisms in the normal eye, secondary deviation. So we need to do more recession of medial rectus in the better eye. And that is the catch. This is known as differential recession of medial recti. So if you're doing 4.5 in the DRS eye, you will do at least 6.5 mm, sometimes 7 mm in the good eye. And the AHP will go completely, absolutely the head becomes straight. And that is a big thing. If they have stereopsis like your patient has, patient will thank you for life because you made the head straight. And you
Yes.
saved the orthopedic bills that she has to pay later on. Isn't it?
Yes.
Plus
Yes.
the cosmetic blemish that KP sir talked about. So you definitely intervene and you operate. Shruti ma'am, please go ahead.
Yes, sir. So seeing like she was a first year student, I think she's
Brilliant.
presented beautifully.
Brilliant.
Yeah. And
In
so
first
just
year, I didn't even know who is stealing, who is Turk, and who is doing. I had no clue.
so, sir, just for all the PG students, I would like a comment on transposition surgeries in DRS, and then we move to case scenarios. One last
Yeah.
comment on that, sir.
So
Uh,
yeah, so like Priyanka has already said, whatever surgeries we do for the horizontal recti, the abduction deficit, that is a deficit of the lateral rectus, will never be corrected. For that, sometimes we do VRTs, and that is of course you're taking care that you don't operate more than 3 horizontal recti in one eye, rather 3 recti in the same eye because of the fear of anterior segment ischemia. Always remember this. So VRT should be done one vertical rectus at a time, preferably not both the vertical recti at the same time. So if you are going to transpose, please do superior rectus transposition to the lateral rectus. Sometimes we augment it, Foster's augmentation, it helps. 8 mm behind and you suture it with a non-invisible suture, all of that.
Yes.
If that helps, and that generally helps, then you don't go and do the inferior rectus transposition to the lateral rectus. So VRT can be done one vertical rectus at a time,
Okay.
with or without medial rectus recession.
Right. So I have just two case scenarios to finish the session. I would share my screen.
Sure.
Yeah. Sorry, one sec.
It's just not full screen. Nothing.
Yeah, I'm making it. It's not going.
Do it from down. No. Put it on that
Ah.
glass.
Fine. So, yeah, just very simple cases. This is a 5-year-old child who walks in my OPD with right eye inward deviation of the eye. Left eye, left deviation. Yeah. Left eye. Everything otherwise is normal. Visual acuity, right eye 6.9, left eye 6.12. I do a dilated retinoscopy of +5. So the dilated retinoscopy shows +5 with 0.5 cylinder at 80 in the right eye, and left eye is +6 diopters. So when I do squint examination, it shows Hirschberg's corneal reflex test, left eye esotropia 15 degrees, extraocular movements full and free, and prism bar cover test shows distance 35 PDET, near it was 35 PDET with no pattern. So I would like to ask the panelists like how people should approach from this case scenario, and go ahead. And she's a 5-year-old child. Yeah.
This is a very interesting starting point to understand that this infantility is categorically termed as a non-accommodating. Later, basically a plethora of accommodative is a you have refractive accommodative, you have non-refractive, you have partially. You should understand that when you see a child, his esotropia is corrected with full cycloplegic hyperopia, is an accommodative element. This is for the beginners, not going to controversy. What is corrected with glasses is accommodative element. What is left uncorrected, what is still squinting even after wearing glasses, non-accommodative element. Okay. So the rule is all accommodative element has to be corrected. Only the non-accommodative has to be corrected. So there is nothing like surgical planning for every esotropia unless you have. So in this child, he said that she had atropine refraction of +5 and +6, and this is very 5-year-old child. So there is quite a bit of hyperopia. So you give full correction. Please subtract for the distance. You may not subtract for the atropine. You may subtract for the atropine. So there are various thoughts. So you give the full correction, and then after the atropine effect goes, reassess it.
So sorry, your voice is breaking. Hello. Yeah.
So you can reassess the child after the full cycloplegic, and then whatever is the esotropia that is remaining, that is the thing that is here. Obviously, there is not much of an amblyopia, so you can actually plan for a surgical case after cycloplegia. So this is something very important, and this can be called as a partially accommodative esotropia, where there is an element of non-accommodative and accommodative esotropia.
Correct. So, sir, as you rightly
of course,
said,
AC by A ratio also plays a big role.
Yes. But sir, I think the prism bar was normal, like was same deviation for distance and year. So then I avoided that. But yes, AC by A ratio should be calculated. So sir, I did a cycloplegic retinoscopy and we found that it was orthophoria. As sir rightly said, we gave the glass trial and it was a case of accommodative esotropia. So the child is wearing glasses now.
Refractive, more of refractive esotropia than accommodative.
Yes, sir. So,
had it been accommodative, then bifocals would play a role.
But sir, that is also an accommodative esotropia with high AC
partially, partially, yeah.
Partially.
So, refractive, partially accommodative esotropia, I would say.
Okay.
But yes, you're right. Absolutely right. Yeah.
Right, sir. So, sir, what are the dilating agents that you use for patients with esotropia, and when and what age?
So as you've already done atropine refraction with, so the point that needs to be put across is use atropine eye ointment and not atropine eye drops. That is really important, 1%. And because drops come with their own set of side effects since they get absorbed in the nasal mucosa. So atropine in high isotropia, yes, up to the age of 4 or 5. Otherwise, beyond 3 years, we don't use atropine eye ointment. I just shift to homatropine. Cyclopentalate, I almost never use because I've seen a couple of very scary scenes with cyclopentalate psychosis in HVSI OPD. Luckily, we had an in-house pediatrician, but everyone is not lucky to have one in-house. So cyclopentalate is very, very dicey, very creepy.
Right, sir. And so the last question is like, so suppose if this was not accommodative, there was an accommodative component and it was just a normal surgical case, would you give patching first and then go in for surgery or directly operate? Sir, KP sir, you can take this question.
I think this child has been it's always so just before surgery.
Sir, I'm so sorry, your voice is breaking again.
Okay, in this case,
better.
Well, I think he and Nikhil both are students of Dr. Sharma. Basically his idea is to actually before the surgery we need to prime the eye, even though it is 6-12. Don't go by the vision alone.
Right.
There is always a dominance of right eye over the left. The left is the weak. So you create some kind of an equality because the friendship happens only between the was a statement. So you do an alternate patching for a few weeks and then you take up the surgery. The results are much better.
Perfect. Okay. So take-home message for the PGs is cycloplegic retinoscopy is must for any child with squint. Atropine preferred for at least till 5 years of age. Glasses should be given and a patching trial should be given before you consider any case for surgery. Okay. Case 2. So this is a 20-year-old child, 20-year-old male, sorry, who came with chief complaints of outward deviation of eye since childhood. He's been wearing glasses since 10 years. So his refraction is right eye -6 with -1.5 at 90 and left eye with -7 with -2 into at 90. So how do you, so again, question to the panelist, how do you examine this patient? Like the squint evaluation in a high myope. And what would be the management? Nikhil sir, you want to take it?
Yeah.
Okay.
So since he's a 20-year-old and already established myopia with almost equal vision, hardly any amblyopia, and quite a large exotropia that I can see in the left eye. So first we establish whether it is a monocular exotropia or alternating, and we are expecting it to be alternating since everything is equal. Yeah. So with right eye fixation preference, distance 50 and near 45.
Correct.
No pattern. So I think it's a straightforward thing. We would just go ahead and operate because there is nothing else at the age of 20. Established myopia, fundus examination done, go and operate. Always have to be careful about when you're operating, since it's a high myopia, be careful that we don't perforate the globe.
Right.
And again, yes, go ahead.
No, sir, said. I just said yes. Yeah, go ahead, sir, please.
So the minus glass power, as you mentioned, or overestimates the squint. So target angle with Helveston stable, it will be a little lesser, about 5 prism, 6 prism lesser. It doesn't change it with a big deal. Now, without the glasses, the prism cover test actually has no importance. So with glasses, prism cover test for near and distance, reduce it by maybe 5 prism, 6 prisms, go ahead and operate. And this will be a 2-muscle surgery only for the left eye. There is no role of doing bilateral lateral rectus recessions because that will not take care of 40 or 45 prisms of deviation. You have to resect the medial rectus. Otherwise, he'll be left with a 20 prisms residual exotropia. And you have already sacrificed one lateral rectus, the other lateral rectus. So you just stick to the left eye like you've already done. Do the lateral rectus recession, medial rectus resection, and you're going to get the, obviously you take a look at the inferior oblique and there is no pattern that you've already mentioned. So LRMR surgery, 2 muscles.
So had it been like a higher angle, would you stage the surgery or just do all together?
So I normally don't do 3 horizontal recti in one go. I always do one eye, 2 recti, and I'll tell the patient if needed, we'll touch the other one. Because I personally, in 20 years, I have never understood how the horizontal recti of 2 eyes interact. I have not understood, and I don't think there is a formula for it. I always will do one eye, Wait for about 6 weeks, 5 weeks, then do the other eye if needed.
Right, sir. KP, sir, your closing comment.
I completely agree because the results are always better in state. You can actually plan your second surgery more. Maybe that will require one muscle or two muscles.
Yeah.
That's better than doing three muscles, and then you do not have really much of.
Perfect.
Right, sir. And sir, last one. If they have to undergo any refractive surgeries, how much should be the gap between squint and refractive surgery? And which one first? Always the
Refractive
debate.
first. Refractive first in myopia.
Okay.
It is a trans PRK and any surface ablation that probably get kind of a get developed with that. Then maybe your thing, because if you have done a opening of the conjunctiva from the, then you can probably in such situation you can always ask the strabismologist for a fornicial approach. Sorry, fornicial or on the muscle approach. Simple conjunctiva on the simple architecture is.
Yeah.
I don't think that there must be any problem because it's an extraocular procedure. You can take up your laser for the refractive surgery.
Right, sir. So, as always, I've learned a lot from Dr. Nikhil and Dr. KP, sir. And very, very nice.
Likewise.
Yeah. Thank you so much, Sumit and Moss and everybody, the enhance, the whole faculty of Moss. Thank you so much. Sumit, all over to you.
Yeah. Kruti, you can stop sharing the screen.
I'll do that. Yeah.
So thank you, KP sir and Nikhil sir, for being here and enlightening all students and all of us together as well. And I would like to congratulate Dr. Aishwarya and Dr. Priyanka. I would not dare to present a squint case in front of both of you even today, but they did very good job.
Just presenting a squint case itself is huge credit in front of anyone.
Sumit, can I ask one question?
Yes,
very basic question.
Yes,
how the panelists calculate the how much recession or resection should be done? Because we still follow the Parsons.
That's a trade secret, sir.
Because we still follow the Parsons chart. So is it okay or some other calculations are there?
I think Nikhil can share the secret.
No, so the secret is that there is no table.
Okay.
And there is nothing, there is no chart that one can follow. Every case, so initially in the first 50, 100 cases, the same millimeter recession and resection are going to give us different results. Then gradually we start understanding what the muscle is and what our interaction with every millimeter of every muscle is. Every medial rectus will behave differently at 3 months of age, 6 months of age, 1 year, 3 years, 6 years. Pratyek hela, there is a different calculation. So there is really no table. So it is age related. It is which one is dominant, which is the muscle. Medial rectus is stronger, lateral rectus is weaker. Hence, you need 2 to 2.5 mm more of lateral rectus for every person. So it's a very different story.
Yeah,
and in
with
adults,
expensive.
and in adults, obviously recessions are less effective than resections. In children, recessions are super effective, so no need of resections. Is my take. So no
It
sacrifice.
depends on many things. The axial length, actually where is the original insertion of the muscle. That also matters. Sometimes, even though we say 5.5 million rectals, some children it's probably at 4 millimeters. So it depends where we start. So it's actually so individualistic, so different for different eyes. But actually difficult to give you one standard. To give a particular case, then we may probably tell. Even then, I would like to confide in Nikhil agree with me that we'll never be sure. It's not like a cataract surgery that everything is fine, the patient is sick. It's always an element of suspense.
In fact, in whichever strabismus book or research papers that we read, orthotropia is defined as 0 to 10 prisms of a result. So that in itself tells us that there is a 10 prisms bridge where what we can call as a good result.
Microtropia is one of the best outcomes of isotropia surgery infantile.
Yeah.
Strabismus is only one subject where everybody has different methods, but finally everybody gets ortho.
And for
All
the
the
same
numbers
millimeter surgery, everyone gets a different result. That's also a
different
lot of fun.
result. Yes, yes. Right. Yes.
Thank you.
Yes. So,
Thank you
thank
so
you,
much.
Dr. Kruti, for taking all dry runs and training our students. And thank you, Dr. Hanumant and Dr. Satish, for taking out time from your busy schedule and preparing our students. Thank you, all of you. And we call it a night.
Yeah. Thank you
Yeah.
so much, everyone.
Thank you so much.
Thank you so
Thank you,
much.
everybody. Good night.
Thank you.
Thank you,
Good
Dr.
night.
KP, sir, Dr. Nikhil.
Thank
Thank
you,
you, sir. Thank you,
Vardhaman.
Sumit. Yes, thank you, everybody. Very well done,
Thank
everyone.
you.
Very well
All the
done,
best.
Thank you
both
and
by
good
both.
night.
Good night.
Great initiative. Thank you.
Thank you. All the best.